Thank you very much for the invitation to participate in this meeting. I think it's terrific that there's so many people here on a Sunday morning thinking about emphysema. God, it's a pleasure to be here for sure. I have a very simple view of this problem of interventions for emphysema, and we've heard several of these options: surgical LVRS, valves. There was some enthusiasm for airway bypass procedure, and I think that's kind of an experimental thing and has not yet reached cruising altitude. And then, of course, there's the transplant option. And this is, once again, I'm a surgeon, not someone as intellectual as Mike, and so this is our algorithm. It's about 20 years old now or more. So we do the same as you. We do have a multidisciplinary group that evaluates these patients. Patients who have severe hyperinflation and low FEV1 and poor exercise tolerance, we tend to offer those patients transplant, although, as I'll show you shortly, transplant has become a less practical option for patients with emphysema, at least in the US. So these patients are, I think, more often those who certainly have heterogeneous disease and some target areas, better exercise tolerance. They are referred for volume reduction strategy, and our bias is to offer a surgical option, and we do all of those operations video at this time. It's interesting to reflect on the first human lung transplant that was performed. Brings out a number of interesting aspects. This is a procedure that Dr. James Hardy performed in 1963, and the lung donor was a non-heart beating donor that died of a myocardial infarction, so the patient was dead. There wasn't no definition of brain death at that time. But the recipient was a patient who had COPD and a left hilar bronchogenic carcinoma, and he had been judged inoperable. It was also interesting to reflect that the recipient was a prisoner, so it's, possibly there might have been some skipping some of the details on informed consent, but in any case, that patient did not survive very long, but it did demonstrate that a human lung allograft could function for a period of time. And several years later, it's an interesting quote from David Bates in the New England Journal: "Any physician who has the sad task of caring for a patient suffering from advanced pulmonary emphysema must on occasion wish that human lung transplantation could offer some hope to these unfortunate patients." And it's interesting that it was about 15 or so years after this that transplant became much more widely used for patients with emphysema. Now, these days we do most of these operations through anterolateral thoracotomies, and in emphysema patients, because the chest is so expanded and there's very seldom adhesions present, we can conduct those operations through separate anterolateral incisions. And this shows a typical result from a right single lung transplant for emphysema. This is a patient that was transplanted years ago. You know, for a time in the early 80s, as we were developing lung transplantation, it was thought that single lung transplant for emphysema was impossible because it would induce a significant ventilation perfusion mismatch. And it was not until 1989 that Andreasen and the group from Paris reported a successful experience with the application of a single lung transplant for patients with emphysema. And subsequently, single lung transplant became a much more common operation for these patients with emphysema. It's actually the radiographic imaging from this particular patient that made us think back in the early 90s that maybe some of the beneficial effect from a lung transplant in an emphysema patient was some restoration of normal chest contour. You can see in this patient how flattened the diaphragms and how inflated the chest is. On a post-op x-ray with a single lung graft in there, the diaphragms are much higher and no doubt functioning at a better level. So it's interesting to reflect a little bit on the history of the development of LVRS and transplantation. It kind of went hand in hand. And this is the typical result we'd obtain from a patient who has a bilateral transplant for emphysema, a near immediate restoration of chest contour and near normal lung function. Now, what I'd like to do is there hasn't actually been that much written about transplant for emphysema in recent years. This is all literature from some years ago. And it reflects the problems that we're having with the application of lung transplant for emphysema in the US. But in any case, this is an important paper that was published a decade ago in The Lancet, looking at a group of patients who underwent transplant for emphysema, and you can see the steady rise of bilateral transplant as an option for these patients. And the reason for that is because those patients have better long-term survival. Bilateral provides better functional results, just like it does in the lung volume reduction patient. And when they did propensity matching on a portion of that analysis, that survival benefit persisted. But here's a problem for the emphysema physicians and transplanters. It was apparent at that time in the mid-2000s that maybe transplant wasn't so helpful in terms of survival, particularly for patients of older age. And you can see that the survival benefit really disappears in those patients of older age. So I think when we think about lung transplant for emphysema, it has less to do with survival than it does with quality of life. Well, around about 1998 in the United States, there was a regulation passed by Congress that demanded that organ allocation be established on the basis of urgency or likelihood of a recipient dying on the waiting list, that time on the list was not the preeminent factor, because prior to this time, the patients who were on the list the longest time had the highest priority score. So emphysema patients, as long as they were participating in a rehab program and were getting good medical care and they were on supplemental oxygen and doing exercise every day, those patients can live for a very long time, unlike cystic fibrosis or pulmonary fibrosis patients or those with pulmonary hypertension. So it took about 7 years to develop a priority scheme that everybody could agree upon, and in 2005 we implemented a lung allocation score which allocated patients by likelihood of them dying on the waiting list, basically. Now, if a patient had a very high risk of dying in the first year after transplantation, that would reduce their score somewhat. But the predominant feature was how likely was that patient to die on the waiting list, and that patient had the highest score. And I'll show you the implications of that subsequently. Meanwhile, the International Society of Heart and Lung Transplantation had matured significantly and continues to do so. You're all familiar with these regular reports that are put out by the ISHLT on the annual registry data. Now, bear in mind that this is a voluntary international registry, but still most busy programs do submit their data to the ISHLT, and in the United States, it's a mandatory submission to this registry. And you can see how these transplant centers are allocated, European, North American, and other. So the majority of busy programs are in Europe or in North America. And interestingly, I don't know if that yellow line shows it, but it's not too bad. That just demonstrates retransplantation, and I'll have a few remarks to say about that, but it's obvious that retransplants represent a very small percentage of the transplant procedures done internationally at the present time. This is an interesting slide because it depicts how busy these centers are. And you can see on the far right, there's a very small number of transplant centers in the US and Europe performing more than 50 transplants a year, and yet those centers comprise about a third of all transplants done internationally. So these centers are busy. They're doing lots of cases, whereas it astonishes me that there's a number of small transplant programs doing less than 5 cases a year. I just don't know how that's practical or beneficial to the center or to the patients. In any case, this now will demonstrate, I think, a little bit the implications of the lung allocation score. So the yellow bar that begins to widen in the mid-2000s is pulmonary fibrosis. Cystic fibrosis in the darker yellow really hasn't changed much, remains relatively constant, but there's been a definite decrease in the number of patients with emphysema who are being transplanted. And now, I don't think that allocation has the same impact in other countries as it does in the US, but it definitely has a big impact for us. As in our experience and others around the world, that this is the international experience, better survival with bilateral lung transplant. There is, it's a complicated slide, but the gist of it is survival is getting better over time in various cohorts divided by decade. And at the bottom, you can see the rather dismal results for retransplantation, although perhaps in recent years they've improved slightly. Just a word or two about pediatric lung transplants. If we characterize pediatric patients as being anybody less than 17 or 18, obviously the majority of these patients are patients with cystic fibrosis. Very few, interesting though, very few number of infants undergoing lung transplantation for a variety of interesting conditions, most of them fibrotic. It's also interesting to note that if you look at that group individually, their survival is not greatly different than the adult group overall. The distribution of centers, Europe, North America, it's about the same. And once again, we see a very small number of centers. I don't understand exactly how this transpired, but in the late 90s, there were a number of pediatric lung transplant centers that were really quite busy, doing more than 20 procedures per year, but now there's very few of those, no center doing that number, but a reasonable number of centers still active in the pediatric population. And looking at survival, the pediatric patients in that blue graph in the middle, they really have quite respectable survival long-term comparable to the adult population as a whole. And in the retransplant situation, which is a big issue for the pediatric population, it's extraordinarily difficult to deny a child a retransplant, and so they do a reasonable number of those in comparison to the number that's done in the adult population. But still, the results are not very satisfactory. Our own experience at WashU comprised about 1,500 patients as of last fall. And you can see the distribution of those. The vast majority are primary transplants, and the vast majority of those are bilateral procedures. Our annual activity is shown up here. It's gone up a little bit last year. We did 83 transplants last year, which was a record for us. And in our own experience, you'll see a dramatic fall off in the COPD recipients in comparison to the IPF experience, which has really more than doubled in the last decade. Also interesting to note, and this is other experience as well, you can see this little graph here on the far right of those with pulmonary hypertension. They really have fallen off substantially, and I think that's just a reflection of far better vasodilator therapy available to these patients. Another interesting problem that transplant programs produce is transplant recipients that need to be looked after. And at the moment, our program is looking after almost 700 recipients, which is an entire very big challenge in itself. Our overall survival is shown here, and once again, better survival for patients who have bilateral transplants. And our experience is better as time goes by. Each of these curves represents a chronologic series of 250 patients, and it's definitely gotten better. So we're getting better as time goes by. And just a word or two about retransplantation. It represents a very small experience. For us, it's 3%. Internationally, it might be 4 or 5. But those are challenging operations associated with considerable morbidity and mortality. Another major issue that troubles transplant programs around the world is suitable donors, availability of suitable donors. We're lucky in our region in that we generate about 30%, anywhere from 30 to 35% of donors are suitable lung donors. That's far higher than any other center in any other region in the United States. But it's given rise to this business of donation after cardiac death, and you're aware of the classification that's been established. In our own program, small number of cases because our results have not been very good. We had a higher incidence of primary graft dysfunction, use of ECMO, and perioperative mortality than our experience overall. And there's a whole number of objections to this potential donor source after cardiac death, and I've just listed them here. And the ex vivo lung perfusion, which I haven't mentioned but is a terrific advance, might be able to help sort this out, because we'd have an opportunity to study the lung, perfuse it, correct it, treat it, and then use it. And that strategy has been demonstrated to be quite effective, particularly here in Europe and also in Toronto. Well, what have we done? But we're far better at patient selection, recipient donor selection. We're better at donor management. We know how to treat donors prior to transplant much better. Ex vivo perfusion is a big advance. ECMO is transformed. It used to be complicated, and now it's not. The technique, no doubt, has evolved. The more cases that are done, the bigger the program experience, and immunosuppression is much more refined than it was. But what are the opportunities for us? We still are plagued by a lack of suitable donors and a high mortality on the waiting list. Primary graft dysfunction, a problem 20 years ago, is still a problem. Chronic allograft dysfunction or bronchiolitis obliterans is the big problem, and we're really not much further ahead understanding that problem than we were 20 years ago. Infection malignancy are big issues in the long term, and most importantly, what busy transplant programs need and scholars need is better funding for outstanding research projects. Thank you very much.